So sometimes it's hard to tease out, is my patient withdrawing? Are they intoxicated? Is it the trauma? Is it other medications? Is it underlying psychiatric illness? Are there some clues that we can use in our discussion with them, in our exam?
I'm actually really glad you asked the question that way, Dr. Nelson, because I think the most important principle that we've got to keep to when we're approaching patients, even in these difficult circumstances, is we need to remain clinical. And what that means in our role is looking for the underlying cause of why we're seeing what we're seeing, as opposed to just saying, we have a safety issue. What's my tool for this? How do I get this settled down and fix it? Because that's not really how clinicians think. They really think about underlying causes. Attention span is actually one of the key things that you're hoping for to understand whether or not patients are doing well. You want to see if they can process new information quickly, if they can pay attention, if they can stay awake, if they know where they are and appreciate their circumstances. Can be still hard to figure out those things, but those key pieces, if we have a patient who can't appreciate any of that, who can't pay attention, who can't stay awake when addressed, keep a level of consciousness that works, and understand roughly what's going on and where they are. I'm more concerned about delirium being the cause of why they may be agitated or confused or difficult. And that's a whole separate pathway of concern, right? Because then that's not a primary psychiatric illness. It's driven by something medical and something concerning that could potentially be lethal and needs to be addressed in a different way. If you want sort of a small package of a micro-mental, if you really do have that 1 minute to be able to do it, what I try to do is, even though the situation is really bad, I try to get my patient to engage with me for a second, and I say, look, there could be a lot going on here. I know that we may not even agree about the next best thing to do, but I'm charged with taking care of you, and I need to figure out some stuff, so I need your help. What I'm going to do is I'm going to give you a few words that I'd like you to remember, and I'm going to ask you for them back. It's a test of memory. It may seem stupid, but it helps me to understand how sick you might be, even if you're not wanting to be here or deal with this. Could you please just do this for me? And I give them 3 words: nickel, pony, table, something like that. After that's done, and I know that they have been able to figure out that those words are there, then I ask them where they are and ask them to tell me about the circumstances that are going on. And even if they're screaming about it, they'll usually say, oh, the cops hauled me in here. I didn't want to put up with this. But you get it that they get what's going on, as opposed to saying something like, I don't know what's going on. Where am I? We're going to school and I have to get to work. And could you call my wife? She's been dead 30 years. That's a very different set of orientation. So you get that piece next. The next piece is for attention. And the way that I test for attention is I ask someone to repeat back something that I've given them, a very simple set of data points. Could be a string of numbers, could be a string of letters. After going through the orientation and the attention, now's the point where I ask for the 3 words that you gave me before, because that's enough of a delay to see if they can hold on to information. Especially if you can be cool about it and say, look, I know this seems really ridiculous, but can we just do these things because this is what I do, and it helps me to figure out what the heck is going on. If you can do this stuff, I don't worry about a bunch of things. You won't have to get a ton of lab tests. That's another way to be reassuring. If you can pass this test, then I won't be worried about doing a million things to you that you don't really want for tests, because you don't want to be here anyway. That's one way to kind of reframe the situation. That might help. The overarching principle is always treat the underlying cause of the issue, right? So if we've identified a delirium, for example, and you have an idea about what might be causing there to be a delirial picture, the most important thing you can do, of course, is to address the thing that's wrong. So if you think someone is hypoxic and they're disinhibited because they're not getting enough oxygen to their squash, the intervention there that really fixes it is not haloperidol, right? They may need haloperidol, but what they need is oxygen. So the same principle applies all the way across the board. You're replacing sedatives in folks who are having sedative withdrawal. You're giving antidotes for disinhibition problems. If the patient is anticholinergic toxic, we've got an antidote for that. So it's always really about trying to target the situation. If you have someone who's agitated now where the cause is not so much a medical concern, but it's really about a comfort or a circumstances concern, you can also knock down a lot of agitation with targeted therapy there too. If the patient's hungry, thirsty, and tired and angry, sandwiches in a bathroom are a heck of a lot better than any Doan or Dol or Peen or whatever drug you want to choose. So I think that's another key piece too, is if you identify that the reason for the agitation is unaddressed pain, unaddressed discomfort, it's important to not forget these tools. If all of these other things are exhausted though, and what you're left with is a nasty person who has had a nasty conflict with someone else and is continuing to act it out with you and your staff in the ED, combining antipsychotics with benzodiazepines together is a common practice, and I certainly support it, because it might be a situation where you don't really know the underlying cause. So by mixing the two together, you get the dopamine blockade help from the antipsychotic, but you get the anti-seizure and anti-arrhythmic help from the benzodiazepine. So mixing together that way is certainly a reasonable way to go. If the picture is undifferentiated, you're just not sure, and safety is an absolute paramount. But I don't recommend mixing in an anticholinergic.
So the B52.
Automatically. Yes, right. So this is 2/3 of the B52, right? This is the 5 and 2 piece. The B part, I'm rarely a fan of.